Hi, good afternoon, and welcome to my webinar on block grafting using maxgraft allografts. This is really the second part to a webinar that I did last month, which was on the bone ring technique, and this follows on to talk about using the allograft blocks. So I'm based in Cirencester, the capital of the Cotswolds in the southwest of England. I've got two practices, and one of them is there. That's my practice in Cirencester. It's really quite a pretty, beautiful part of the world. A little bit about me. So I'm an ITI fellow. I am an ITI mentor. I'm an ITI speaker. I'm the study club coordinator for the UK and Ireland, which keeps me very busy on the World Dental Practice, as I've said. So I have an active relationship with Straumann, and as you can see, I go on the Straumann bike rides. Very keen cricketer, and that keeps me busy through the summer, and just enjoy my family life, and that's what puts it all into perspective. So that's an important family life. That's why we want to do things right, and that's why I like using products that really do work well in my hands. I'm incredibly active surgically, so I do all kinds of surgery, but most importantly, I also restore all of the implants that I place. So when we're talking about bone grafting, really the idea is to reconstruct a deficient ridge or correct bone deficiencies to a form that will ensure an aesthetic and functional implant-supported restoration, i.e. we've got to rebuild what's lost. So with that in mind, we want to ensure that we get a predictable long-term and stable aesthetic outcome, because that's, after all, we need to provide patients with teeth, not just implant crowns. We need to improve biomechanics, so that's ensuring sufficient volume of bone around the implant for long-term stability of soft tissue, and therefore long-term stability of peri-implant health. And then, and in relation to that, we need to improve the access or form for hygiene. So sometimes you can get very strange shapes of crowns unless you rebuild the ridge adequately beforehand. For example, things like ridge lapping. So I'm going to cover everything in a little detail. So obviously in terms of block bone grafts, we can use an onlay graft, and that's what we talk about when we're talking about the allogenic blocks. We can use interpositional grafts, things like ridge splitting, and then we can use particulate meshes, so rigid membranes with particulates to recreate a ridge form. And we can manipulate bone, so we can either expand it or split it, or we can try and stretch it with distraction osteogenesis. I can wholeheartedly say I've not tried distraction osteogenesis. I think it's an incredibly technique sensitive process, and it's not widely conformative at the moment. Bone manipulation, I've done quite a lot of expansion, splitting, with mixed success rates, and I still think really the best solution for me in a very deficient ridge is an onlay block graft. So if we look at the Cawood and Howell ridge classification, just to refresh our memory so that we know what we're talking about. Class 1 is a dentate ridge, normal alveolar structure. Class 2 is when we take the tooth out, and it's immediately post-extraction. So there's still the thin buccal plate, thin lingual plate. 3 is a well-rounded ridge form in adequate height and width. This is, the slam dunk of implant dentistry, where we've got basically very, ample bone to put our implant into. Excuse me. Then we have type 4, which is a knife edge ridge form. This is what we're kind of talking about, where you lack adequate height sorry, where you've got adequate height but you have inadequate width. And typically this can then eventually get to having fused cortical plates, which then negates any ridge splitting procedure that you might want to do. Type 5 is a flat ridge form with inadequate height and width, and that's where your bone ring technique can come into play. And then you've got type 6, which is your depressed ridge form, which is where you're down to basal bone. And that's the complex grafting cases. So just a little schematic to demonstrate that. And so we're looking at 4 where where we've got adequate height but inadequate width. So it's this area here where we want to regenerate. So and again, so it's this area here that we need to regenerate to form bone. So clinically, with a little Rochette bridge in place, you can see there's a very large alveolar defect underneath that Rochette bridge, and that is not going to be solved by ridge splitting or any expansion technique. That needs some form of augmentation procedure to provide sufficient volume of bone for implant placement. As we can see when we raise a flap, and really there is very little width of bone here. And you can see on the adjacent teeth that this patient has a thin biotype. We've got probably fenestrations, root fenestrations where we've lacked the buccal wall. So then if we look at the types of grafting material that we've got available, we know with the literature that they need to be osteogenic, i.e. an autogenous block graft will have living osteoblasts within the donor site, within the donor graft. That graft material has its own potential to regenerate. Then osteoconductive is where we have a graft material that's got a scaffold where we encourage bone formation. So it's the scaffolding to allow blood vessels to form, to get angiogenesis, to then allow cells to migrate in and get osteoblasts rebuilding bone. And then we have osteoinduction, where we can apply the patient's own growth factors or even bone morphogenic proteins, BMPs, into the graft material to try and transmit signals to induce bone formation from the osteoblasts. So i.e. try and make something that wouldn't normally be osteogenic, give it osteogenic potential. So if we then look at the different types of material, so we've looked at the characteristics. Now if we look at the types, you've got autogenous, which is donor, same recipient. So it's taking a chunk from somewhere else, be it intraoral, extraoral, and refixing it in the implant site. Then we have allogenic, which is what we're going to be looking at today with the maxgraft, where it's a donor human, and the material then gets reprocessed, so it negates the need for second surgical site, and really we can get quite large quantities of bone available for grafting. So the only difference between that and autogenous is that it lacks osteogenic potential. So it's very osteoconductive, but it's not osteogenic. Then we look at xenogenic, which is your typical bovine-derived materials, such as cerebone, and that again is osteoconductive. It's not osteogenic, and it's generally in particulate form. And then we have the alloplasts, such as maxresorb, which is fully synthetic, and again that's granular form. So if we look at, as I've said before, I work closely with Straumann implants and the SLA active surface, and all the componentry fit together nicely with all of the different biomaterials we now have with botiss, and the symbiosis between Straumann and botiss is fantastic. And you can see from here that we have our our Jason membrane up here. We can have our particulate form. We can have our thicker membrane form. We can have collar cones. We can have injectables. We can do a 3D CT guided bone regeneration, which I will come into later. But now we've got the block formation, so we can simply out of a packet get a block of bone. So if we look at the family of maxgraft materials, so then our allogenic bone, so our human donor bone, can come in different guises, and I've alluded to the maxgraft bone ring, which I've already, as I said, I've already done a webinar last month on that, and that's a fantastic solution. That's to regenerate height and width of bone at the same time as placing our implant. We'll come a bit later to the maxgraft bonebuilder, where we can design through CAD technology, through CAD software, a bespoke milled bit of maxgraft, bit of donor bone to fit a recipient site. Then we can have it particulated, and again, as I said, we've got Cerebone, MaxResorb and MaxGraft, and they're all particulated. Then we have our blocks, maxgraft blocks, and we'll go into those in a bit more detail in a bit. And then we have the Jason membrane, Cold Protect, Mucoderm, different barrier membranes. I typically use Jason routinely. So if you're not familiar with, you should be familiar with the botiss indication matrix, and that's on the website, and that really covers all of the different indications and materials that are suitable for different indications of grafting materials. So as you can see from this screenshot that I've taken off the website, we've got, you can look at the block augmentation, you can look at GBR, you can look at ridge splitting, you can look at the bone builder, and then it will, you click on the plus sign, and then that will expand it into further indications and further information. And to continue with that, there's socket preservation, there's ridge preservation, shell technique, and other, natural healing, which I quite like, and then the block augmentation, autologous blocks. So it's a very wonderful tool to be able to use. So if we look at maxgraft granules, because they're quite important, two variations. You can either have purely cancellous, or you can have a mixture of cortico and cancellous. I, on the whole, just use cancellous, and that's just pure personal preference. I think it absorbs blood, just seems to be like a little sponge, and it's just forms a lovely scaffold by which you get angiogenesis and then bone formation by secondary intention. It really looks like bone as well. When you get a little bit of blood in the material and it seeps into your defect, it really does look, it then just looks like a ridge. As you can see in this clinical case, I was placing a fixture in the lower four, and it's a classic buccal dehiscence from a previous extraction site, a lower canine that had a fused buccal plate. How often do we see those? Good, excellent primary stability. Pack a load of maxgraft granules in and around that fixture. Place a membrane over the top, and then that's the ridge form and the tissue contour. And you can see that I've obviously taken out the four, and it's part of a lower full arch, but just the soft tissue around that fixture just looks like normal bone, and that's typically 12 weeks later. So here we go. We look at the cancellous blocks, and again, as I've said earlier, you can really, there really is no limitation in terms of what's, how much you can get. It all comes from a packet. We have the bone ring, cancellous bone rings, and again, once they go into place, they just seep up any blood. It's like a little sponge. And then the maxgraft bone builder, where from a CT scan, we can design a bespoke block to fit socket into a recipient site that can then be fixated, and I'll show you a case of that later. So if we look at maxgraft bone blocks in a bit more detail, we've got cancellous blocks, and they're from a living donor. So little old lady has a hip replacement, and instead of the femoral head going in the bin, basically it gets reprocessed, and it gets reprocessed into blocks or grafts or particulate or rings or CAD-CAM bone builder. But in a difference to that, we can, in a way, replicate a autogenous bone graft by having a cortical layer of bone on our block graft in the form of a cortico-cancellous block. And that is actually, because it's sourced from the tibial plateau, so the straight area here is where we get this cortical layer from. They're actually cadaveric donors, so they're non-living donors. And actually, sorry, I should have updated this slide. They are actually fairly freely available. In terms of the other blocks for completion, you can actually get cerebone blocks and max resorb blocks, and excuse me, and max resorb cylinders for the bone ring technique. The problem with these is that they're very brittle, and so I much prefer to use an autogenous, an allogenic, sorry, block, because the just crumbly handling characteristics, properties are not ideal. So, but obviously, if you have a patient that is strongly against having any allogenic products, then perhaps you can use these. You can try. My favourite, and I really do love this material, the cancellous blocks. So, as I said, it's from a living donor. The patient can be completely sourced from. They can have all their bloods sero-tested, so that they're very safe donors, and you can demonstrate. You can talk to that with the patient. When you get them in their packets, they're all sourced from. They can all be traced back through the audits to the actual living person that donated it. And as I said, it's great because there really is no limitation on size and volume of graft that you can use. Again, the cortico-cancellous blocks, cadaveric donors, and yeah, I tend not to use these, and I shall go into reasons why later on. So, if we look at the relative gold standard, should we say, which is autogenous block grafting compared to the literature, we've got various intraoral and extraoral sites, and I just wanted to go through these and look at the comparison of what we do to our patients. So intraorally, we have the ramus, the symphysis, and the tuberosity. And for years and years and years before I had the opportunity to use botiss allogenic products and maxgraft and really begin to love the products, I was doing this to my patients. I was taking chunks of bone from the wisdom tooth area, so creating a second site morbidity, taking it from the chin, and at the same time, having a recipient site, opening a second site of surgery, and taking a chunk of bone from elsewhere, opening a flap or a recipient site. I would perforate it to get angiogenesis going on, to get some blood flow going, some blood perfusion, shape the donor site, fixate the donor site, fixate the recipient site, fixate the donor into the recipient site, and then add a slow substitution rate material, such as cerebone, around the autogenous block graft. perfect for horizontal ridge augmentation. If you're trying to use a block to get vertical augmentation, that's incredibly tricky, and you would need a J-shaped block from the ramus. But we know that with sound surgical technique and passive free soft tissue closure, that blocks do have a lower complication rate than particulates with, say, a rigid membrane, such as a non-resorbable membrane. So just to remind you, this is how you can actually rebuild width and height at the same time with the bone ring technique. It is documented as less predictable than for width, and that's because the soft tissue closure really is an issue, and you must be able to really get passive tension-free closure, and because of that, the complication rate is higher. And then, as I said, the bone ring is fantastic for a localized vertical defect. But we must stress that bone augmentation procedures should always follow a prosthetically driven plan to allow ideal 3D implant positioning, because ultimately we're coming back to the original statements that we made, that we want a biomechanical, an aesthetic and a functional tooth structure that is easily cleansable, but also that it's got, obviously it's got to look like a tooth. So the crown proportions have got to be the same relative to the adjacent teeth, and interproximal regions, and so we do need to plan the case appropriately. So if we look at, I'm going to look at the alternatives to the allogenic blocks before I show you a couple of cases. And so when we're going to the mental symphysis down here, a lot of people can be fooled into thinking that it's quite an easy site to get quite a large graft from. If you've got a very, then yes, quite often there is a lot of bone that can be harvested. But in your typical kind of, well, in my practice, English ethnicity, if you like, then they're more bordering on a class 2 skeletal relationship. So really they don't have big chins to use, and there is a lot of morbidity in terms of limitation of bone. We can often get neural damage to the lower incisors because we have to go, our superior cut for a mentalis block has to be at least 5 millimeters below the apices of those lower incisors. So that means we're really getting quite low down here. And then that then can interfere with the muscle attachment for mentalis. Which if we go too far and we go through mentalis, we can actually give the patient a floppy chin. They might lose the tension in the chin mentalis muscle. So it's not a very easy site to graft from. Tuberosity, often forgotten about, is very low morbidity in terms of grafting, and there's quite a nice punch technique where you can take a connective tissue graft at the same time and an epithelial graft along with a block graft, or a block of fairly cancellous bone, and that's the problem, is that really the quality of the bone is poor. It's very spongy, very porous, very inorganic, and really, it's limited to very small reconstructions. But it does have its benefits. If you've got a nice tuberosity, you can actually use a little bone scraper and just scrape away some little autogenous chips very easily with a minimal discomfort second sight surgery to the patient. Bone harvesting from the ramus again, offers very good quality bone and quantity, relative quantity. But again, you've got some big blood vessels. You've got the lingual nerve that wraps over the wisdom tooth area. Quite often, you have to lose a wisdom tooth to create the space to take a wisdom tooth out, let it heal for 3 to 4 months, then come back, then graft, then leave that to heal for 3 to 4 months, then place the implant. So that, you quite often get very lengthy treatment plans with ramus grafting, with using the ramus as a donor site, and also patients can get quite a lot of swelling, and in terms of practice building and making yourself popular with your patients, when they come out from their big grafting procedures with hot packs, cold packs, either on their chin, strapped to their chin, or strapped to the wisdom tooth area, they are quite painful post-operatively. So reaching to a packet is quite a preference for them sometimes, not to be underestimated. Then extraoral sites, if you've got a decent orthopedic surgeon around, the iliac crest can offer very high quantities of bone, and this is getting into quite complicated, big reconstructions now. But if you are going to refer patients or work with an orthopod, then it's worth knowing that the cancellous bone component is very high, and it does, especially in the literature, lead to higher risk of unpredictable bone resorption. You can really see, typically 7 to 10 years down the line, we get real grey shine through of the implants where these big reconstructions have resorbed quite considerably. And something that's not discussed that often is that from the anterior portion of the iliac crest, if that's where the graft is taken from, if the orthopedic surgeon moves anteriorly, then it can actually lead to gait problems. They can sometimes, it has been documented that patients can develop a limp. We need accurate modelling and stabilisation of the graft with screws, and as I've said, tension-free primary closure. And what isn't documented that well is that you need to overcorrect a defect with an autogenous bone block, because by 25% to compensate for graft resorption. Now you can reduce that by using slow resorption rate materials such as bovine materials, such as cerebone, over the top of that prior to then putting your membrane on. But even so, you've still got to overcompensate the graft material, which then or graft dimensions, which can then lead to your issues with tension-free primary closure. And I've just covered that. So sometimes short, reduced diameter implants, short, narrow implants are indicated for economical and biological reasons. Some patients, health-wise, systemically, just won't be able to go through, or shouldn't go through, these quite invasive grafting procedures. And we know that with the literature now that shorter implants and reduced diameter implants. So there is a place for it, and even in my clinical practice, I'm doing less grafting now than I was, say, 5 years ago. So then the question is autogenous block bone grafting the gold standard? I would question that, and I think the problem we have is that there's not enough in the literature to say yes or no either way. But certainly what we know is that the maxgraft works very well, and there's botiss can supply lots of papers on this, documented over a 10-year period. So we know that allogenic bone works, and that actually we get quite successful results long term relative to the other techniques. And the ITI consensus paper now says that survival rates of implants placed in regenerative bone are comparable to those in native bone. And again, this comes down to, I think, certainly our understanding of grafting materials, biomaterials, indications of the biomaterials, and really us utilising the biomaterials in the most appropriate situations. It used to be that there'd be like a one-stop shop biomaterial that could solve everything, and but that's different now. We have many different solutions for many different problems, and I talk to my patients about, I have a toolbox, and for whatever that particular situation I'm presented with, we go to the toolbox and we find the most ideal solution for that patient. And of course, I discuss it with the patient, go through all the variables, the pros and the cons, and we can look at what's going to work best for that patient in the long term, given their age, their health, the site, the number of teeth, etc., etc. So, just want to cover the disadvantages. Second site morbidity, we've discussed that. Neurological, vascular trauma, a lot of post-op bleeding, infection, scarring, limited availability of bone in certain sites, increased surgery time, so it takes longer. Obviously, if you've got to numb up a second site, open it up, harvest it. If you're competent, if you're surgically competent, then this may even only be an extra half an hour in the appointment time. But even so, it's still more time for your nurses to go through post-operative instructions, and your clinical support team to go through with the patient, because they do need a bit more care. If you've got a second site in that patient, they've been in the chair for 2 hours, they do need that extra time to be looked after, and they have higher complication rates. We can get graft dehiscence, and we need graft compensation over contouring, and compliance from the patient. They've got to maintain it, you've got to clean it, look at it. So just to show you grafting complications, so we have graft dehiscence, and this is typically, and I would approach this case slightly differently now, because this upper bridge is mobile, the fore is, you can see it's had an apicectomy, it's just hanging in soft tissue, so it gets removed, there's a denture, you can just see there's lots and lots of scar tissue there. When you open it up, even more scar tissue. So measure for the block graft, go and harvest it, take a chunk of ramus, it's all measured up, it's over contoured, rebuilt, sutured closed. But what we know is that we're going to get, where's my arrow gone? All of this area here is from that previous scarring, and so that is going to be a really high rate of graft dehiscence. You can see it's really thick, and I certainly didn't, this was quite a few years ago, didn't get primary closure, and it certainly doesn't look passive. But that if that's okay, that's a beveled incision, that's going to heal by secondary intention, so it's not over our graft, which is here. That being said, the graft, the wound breaks down, and we get graft dehiscence from a lack of primary closure. And that's all because we've got scarring here, and not dealing with that really before we attempt the surgery, and not getting adequate primary closure, not dissecting out the tissues, not taking the time to ensure that it's all very, very passive, that soft tissue, that flap just gently fills down. So this is another little one where we get some graft resorption. So again, an upper lateral that had external root resorption, nice draining sinus, an old metal ceramic bridge, resorption in the deep, apical resorption, a big defect, again scar tissue in the site, so to rebuild the width. So this is where I used a template, so you can see we've got some big vessels down there. It bleeds a lot. Get decent graft size to fixate. And in this case, we get graft fracture. So you can see that there's nothing more annoying with an autogenous block, is that it's generally the last turn to try and get that extra little bit of fixation, and it goes and it cracks, and we just get the graft fracture. Does it matter? Not really, as long as you've got good graft stability, because you effectively end up with two block grafts held in by the one screw. Membrane over the top, and what you can see there is that I've not used a slow substitution rate. So the patient didn't really want a bovine material. Get a little bit of wound breakdown from the denture sitting on top, and graft resorption, so loss of the vertical. Good integration. A couple of fixtures placed, and then you end up with pink porcelain. So, with any type of block grafting, we need tension-free closure of the tissues. Otherwise, we get wound dehiscence, and we've got increased morbidity from two surgical sites, and it's very technique sensitive. So if we look at maxgraft allogenic blocks, so as we said before, we've got the donor to the recipient. Maxgraft granules. We discussed this, so I just wanted to recap. So again, I'm just checking that somebody's got a black screen, but hopefully you're okay. So the cancellous blocks, the corticocancellous blocks, the granules and blocks. And if we look at a clinical case now, so instead of having to go to a second surgical site, we can now go to a packet. We have an upper lateral here where there's been a history of apicectomy after apicectomy. Got a big area, healthy site in a young, a young lady in her mid to late 20s, I think, possibly early 30s. And when that tooth is taken out, you can see the problem all the way along has been that fissure through the palatal aspect of that root, and that's why that tooth has failed and all those apicectomies have failed. So this is how the lady presented to me, was with a Rochette bridge, which I showed you earlier, and big scarring defect, really big. And so then if we look at the CT scan in a little bit of detail, you can see just how much ridge we've lost. Now, what we can see is the prosthetic outline here. So the emergence for me, I'd like my screw retained implant through here. So we have lost a bit of height, but we've lost an awful lot of width. So then when you see it with the Rochette off, you can really see there's a very large buccal defect. You can't ridge split here because that is likely to fused cortical plates, especially from the CT scan. And again, so we saw this when we exposed it. That's the block. That's how it comes packaged. This is where, this is how we know exactly where it's come from. Completely traceable from the tissue bank in Austria. So there's the block, cerebone in a little bit of saline, soaking. I just like to moisten it. And then that's the adjusted block, trimmed, fixated inside. Very, very easy to do. And what you do notice is that literally all I've done is just screwed that into place. And as I've said, just the blood from periosteal release that you can see up here to ensure passive free closure. By incising that periosteum, we get a lot of blood flow. And one of Ross's top tips is to do that. If you do that as soon as you open the flap, then eventually that bleeding will slow down or stop. And if you do, and therefore the blood will go up the suction pipe, as opposed to if you do that last thing during the surgery, just before closure, then you get a lot of swelling, a lot of post-operative bleeding within your surgical site, which can lead to a hematoma and post-op swelling and discomfort and bruising. So the earlier you do your periosteal release during surgery, the better. Obviously, sometimes you need to go back and you need to just release the tissue a little bit more, which is fine. But then I would still say again, just let it bleed out a little bit, let it go, let the blood go up the suction pipe a little bit, so as not to be stuck within your surgical site. Then you pack it with your cerebone, your low substitution rate, just to really create a nice ridge contour. So you can really see that's going to thicken up, really thicken up around the sides, not necessarily over the top. Jason membrane over the top. And then I use a PRGF technique, so where we extract blood from the patient, we take out their own growth factors, and we form these little fibrinous clots of growth factor. So in the UK, botiss aren't supported by Straumann for LPRP, but so you can use this PRGF technique with a different company, but yeah. So this really helps for soft tissue healing and any concerns of graft dehiscence. Really accurate passive primary closure. Just really can see how there's quite a big augmentation in there. And I always say to the patient, it's going to feel like a marble. Please don't play with it, because it will feel like a marble in your mouth, in your gum. And so, again, you know, that just looks like human bone, doesn't it? Very synchronous. You can see the granules, the cerebone around the outside, but that just looks like it could be an autogenous block 4 months later after healing. And so then that is 6 weeks healing. Just review it at 6 weeks. You can see that the rochette, the emergence profile of that rochette is so much better. And obviously that's going to take time to heal. You can see all the previous scarring from the apicectomies all up here. And that will just improve with time. So at 4 months, we re-CT, and there we go. You've got integrated bone volume. You can see that that neck of that tooth now, prosthodontically, is coming. So if I place my implant there for screw retention, it's going right out the cingulum absolutely perfectly. So we've got a very good, very successful width augmentation. I think you'd agree. So then we come back, we take the rochette off. That's it. 4 months later. Interestingly, when I go back into these sites, we've always got non-integrated particulate material. So the membrane is resorbed, but clearly some of that particulate granules hasn't integrated. And obviously because it takes 6 to 9 months to integrate. Take the screw out, take the fixation screw out, and then prepare and place the implant into allogenic bone. But this is slowly becoming autogenous bone. At this point, I actually use a little bit of Emdogain around for soft tissue healing, which is a Straumann product. And again, really important, passive tension-free closure. And so again, that's at 6 weeks. Got a lovely ridge form, implant in place, scan body. Little screw retain crown, very straightforward aesthetically. And my shade taking is terrible, but good papillae formation. That papilles filling in, but most importantly, we've got biomechanically excellent soft tissue adaptation around that implant. So if we look at 2, which is a bigger reconstruction, you can imagine that's a very big defect. So the rochette, temporary rochette, you can see there's an enormous defect here, all around here. So we've got a 2 centimetre by 10 by 10 graft. Again, fully traceable lot number, processed human allografts, cerebone, Jason, all ready. My little toolbox. That's it fixated in place. Again, you can see, a big wide flap, periosteal relieving incisions all the way around. Going to pack with lots of cerebone around to get slow substitution rate, and then Jason membrane over the top. You can see flap advancement, nice passive tension-free closure. Again, that big block, and that was a big augmentation. That big block fixated in place. It really just looks like human bone. See, it's porous, probably slightly more porous than autogenous bone. That's it at surgery. So we can see it's rebuilt the width. That's it. That's at 2 weeks. You can still see it's at 2 weeks because we've still got a couple of sutures. So it looks fab for 2 weeks. 6 weeks, or possibly even 3 to 4 months. And lovely ridge form. Just no signs of inflammation. Good ridge form. So we can see that the fixation screw has got bone around it. All of the biomaterial is there. It's all intact. So we placed in the 1-1 and with a distal cantilever for the 2. Again, passive tension-free closure with a healing abutment on the left one. And that's it. 6 to 8 weeks. 8 shaped incisions. Scan bodies. Createch framework for screw retained bridge. This lady's got a very low lip line, so we decided to keep a decent embrasure space so that she can easily get a TP through there, just for a bit of cleaning. But I mean, really, in terms of where we've come from to where we are, it's quite a fantastic result, and she's very happy. And you can see that that tooth, that ridge we've not got full vertical reconstruction, but that was never the goal. We were after width. So 2 very healthy integrated implants. So then finally, I just want to show you a case from a bone builder where the workflow is CT scan, upload it through the botiss website, design your block, it gets milled in human bone, and then it gets fixated surgically. And because it's designed through the CT, it fits very precisely. So again, typically 4 months for a maxgraft block to integrate. There we go. So CT scan on the design. Virtually place the implants where we want them for the diagnostics. Design the block. So big J-shaped block. Big membrane to go over the top. See a very narrow ridge. Expose it. Perforate the ridge, the cortical plates of the ridge. Bone in situ. Fixate it. They actually go in and they're quite precise in the way that they sit in there. And we'll pack it around. Bind it with a Cerebone, again, slow substitution rate. Membrane over the top, Jason membrane over the top. Wrap it through lingually. PRGF, just in case of non-passive tension-free closure, and to protect our biomaterial and our graft, and add osteogenic potential. Osteoinductive potential, sorry. Suture closed. Lots and lots of sutures. Nice and tightly closed. And for a very thin, for a tricky mandibular reconstruction, that's a great solution. And on there I'll stop. So I'd like to ask you for your questions, and I hope you thank you very much for listening. I hope you've enjoyed it. So Tony, thank you very much. I trim my blocks with either there's a diamond disc that you get as part of the bone ring kit, or I have a sterile, similar to an acrylic trimming burr that I use in my surgical handpiece, but with locking forceps to hold it very still. And the blue sutures are Prolene sutures. I hope that answers your question. Jason, the last slide, did you do a histology on it to see if vital bone? Not quite sure what you mean by that, but I don't routinely, I don't do any histology, no. Vent a sinus lift and do a block graft instead. Potentially, you can use a vertical bone ring technique for the maxilla. The one thing I would say is that primary closure is difficult because you typically, when you lose those big volumes of bone in the maxilla, you get quite thick, fibrous connective tissue and keratinized tissue. So the primary closure is difficult. But I would, one thing you could do is you could put a block graft within the sinus, and again you can use the bone ring technique with that as well. I hope that answers that. Dr. Alaquili, how can I generate bone build graft? How can I bone build graft? I would I would contact your local botiss representative, and they should be able to help you. I think with the bone builder, you just basically need to have a CT scan. I would do all your normal diagnostic work, and then approach it. with your botiss rep. So do a normal diagnostic wax up, do a normal CT scan, and then with your botiss rep, upload the CT into the bonebuilder, and then you should be able to design it from there. Thank you, Jason, and thank you, Andre. Wolfgang, how long do you wait normally after an augmentation with this block till implant surgery? Excellent question, thank you. Typically 4 months. Depends autogenous block there is, autogenous bone there is for my implant to go into. For case 1, I'm looking more 4 months than 5 to 6 months, because she was a very healthy young patient. She healed very well post-operatively from the extraction, and so typically about 4 months. Is it possible to do vertical augmentation? It is, but vertical augmentation is limited by where the bone is on the adjacent root surfaces, and it's, again, you really need good soft tissue management. So it's not impossible, but it's not easy. So I hope that answers that. Why do you use Ceresorb along with the allograft block, one on a xenograft? I use Cerebone, which is Cerebone is a xenograft, so it's bovine in origin. So that's quite easy to answer, which is obviously a slow substitution rate material. Dr. Karamitsos, how do you treat an unexpected exposure of the graft? So if you get graft exposure, you can either raise a flap, so numb the patient up, raise the flap, open it up, try and get more periosteal release, or you can try just reducing the graft height until you get the graft closure through secondary granulation over the top. So if you imagine, if you've got graft dehiscence like that, what you want to do is reduce the height of it until it goes subgingival, and then hopefully the two epithelial sites will connect like secondary closure. Javier, the two sutures I use are either Proline or Vicryl Rapide. So yeah, hopefully that answers that question. So and to qualify that a bit more, with Vicryl you can get, unless you remove them at say 10 days, you can get a little inflammatory response as they start to degrade, where you get bacterial infiltration. So if you want really, really crisp, clean surgery, use Proline, because it's a monofilament and you don't get any bacteria sticking to it in highly aesthetic cases. Thank you, Wolfgang. Thank you, everyone.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.